Just check the names of the doctors if anybody needs to be moved. No. See I've given you the names. Only those you need to check. Yeah. So we'll get started, sir. Ma'am, can we get started?
Yeah, sure.
Yeah, I mean, are we expecting more panelists to join, or you have any?
Yeah, so panelists will join, but I think as and when they join, we can just promote them. If they sometimes they may join using the regular link, so we just promote them. The admin will take care of that. But I think as of now, we don't have anybody in the attendees as well, apart from the all of so.
So, who are the attendees, Kamal?
Attendees are various. We've shared the flyer with Dr. Ratna and Dr. Aditi Sinha, so they might have shared it with their colleagues and so on. So
No,
we
that's
requested
okay.
them.
Yeah, don't worry.
Mix of nephrologists and geneticists, sir.
No, it's good to have a group of people,
Yeah.
I can recognize the geneticists joining, and I had shared it with our nephrology colleagues, so they too would be. He had said he had put it into all their groups, even adult nephrology.
Okay, good afternoon and welcome to everybody who's joined this meeting this afternoon on the topic that we are discussing today is optimizing the diagnosis in atypical hemolytic uremic syndrome, and the Atypical HUS India Foundation, in collaboration with AstraZeneca and NephroPlus, are organizing this this meeting, and we really hope to have a good discussion on arriving at a collaborative approach that integrates both nephrology and clinical genetics. And I think all of us are working towards this common shared goal, which is optimal patient care. We hope to be able to at least begin to have a discussion towards establishing concurrence on what we are calling a streamlined pragmatic pathway that can be applied across various care settings. And we would really like to articulate the role of nephrologists and geneticists in this whole process. So we have some of the country's leading clinicians and researchers in the area of atypical HUS, nephrologists, pediatric nephrologists, and we have some stellar geneticists also joining us this afternoon. So without further ado, I'd like to hand it over to Dr. Ratna Dua Puri, who is a professor of genetics and chairperson of the Institute of Medical Genetics and Genomics at Sir Gangaram Hospital in New Delhi. She has advanced training in pediatrics and medical genetics as well. Dr. Puri is a leading figure in rare disease research, currently serving as president of the Society for Indian Academy of Medical Genetics and contributing to global initiatives such as Undiagnosed Diseases Network International and WHO expert panels. Dr. Puri has received several prestigious awards, including the Dr. I.C. Verma Outstanding Researcher Award, and has authored more than 160 publications in the field of genetics. Her research focuses on undiagnosed diseases, AI-driven genomic diagnostics, and conditions like familial hypercholesterolemia, advancing precision to take this forward and introduce Dr. Baga and then invite him to speak. Thank you so much.
Thank you so much, Mr. Kamal Shah, for this great session that you've put together. Greatly appreciated. And without wasting any more time, I would like to introduce Dr. Baga. I think he's a very, very well-known name in India. Dr. Bagga is a very highly respected senior pediatric nephrologist from India with over 38 years of experience in managing kidney diseases in children. He has been associated with the All India Institute of Medical Sciences, where he served as the professor and the head of pediatric nephrology. Dr. Bagga has made very significant contributions to clinical research, guidelines, and academic literature in pediatric nephrology with extensive publications and global collaborations. He is widely recognized for his expertise in conditions like atypical HUS nephrotic syndrome and for advanced pediatric kidney care in India and international, and has also a very, very nice publication, I think in 2019 in the Frontiers on his work on atypical HUS. So over to you, sir, and we really look forward to a great session.
Thank you, Dr. Puri. Thank you, Kamal, for this opportunity to be here. Hi, Nirja. Hi, Dr. Aditi, and others. Thank you for joining and this session, in which we'll try to speak from a perspective uh, regarding the diagnosis and prompt management of HUS in adults as well as in children. So the definition, the classification of HOS is evolving, and this is the most recent classification, that is likely to come up over the next couple of years, in which you still have stick HOS still being a very important organisms all over the world. It is much less often seen in India, um, chiefly because of our dietary habits and so on, and Shigella dysentery not being very important currently, and enterohemorrhagic E. coli not really being an important organism. And then the other group, large category of atypical HUS, is now likely to be renamed or reclassified as complement-mediated TMA. You would have TMA, which is non-complement-mediated also, which is shown here, genetic non-complement-mediated. And majority of this complement-mediated TMA worldwide would be genetic. Although in our country, you do have a significant proportion of factor H autoantibodies that would really be accounting for the complement-mediated TMA. In addition, in adults, you have this large entity of TTP, and we'll be discussing this as we go forward. That and because the clinical phenotype would be almost similar with microangiopathic hemolytic anemia, thrombocytopenia, variable degrees of kidney injury, and CNS manifestations. So TTP is an important category in adults. There are some other secondary causes that are fortunately less common, but again, wherein complement has been involved to varying extents. Not so. Just to highlight, that in pregnancy-associated TMA, you could have a complement getting involved, transplant-associated, particularly bone marrow transplant-associated, and other conditions. Even hypertension-associated TMA, people have shown that the complement, and we have one slide on this as we discuss further. So, Kamal, should I ask for comments here about this classification, or should we just go forward?
Maybe we can go forward, sir, and then at the end of the talk, we can take some questions.
Okay, next slide, Dr. Aditi. So, if one looks at the spectrum of atypical HUS, this slide is labeled pediatric atypical HUS, but the last column talks about adult HUS as well. And that's from the global registry. So whether you look at pediatric or adult HUS, almost 2/3 of the patients, you would find an underlying complement disorder. And you can see this figure across. The first column is the French registry, then the Italian. This is the pediatric registry from the global data, and this was the adult global. We'll come to the AIMS data later. But broadly speaking, almost 50% to 60% is complement mediated. And the common complement genes for our genetics friends here are really CFH, CFI, MCP. These, in fact, the commonest two are CFH and CD46. And they would really account for a very large proportion. The others are less common. Some of them are gain of function mutations, particularly for C3 and factor B. But whereas the others are loss of function. CFI is variably penetrant and so on. DGK is a disorder, a gene that chiefly affects very young infants. So kids below the age of 2 years who present with HUS and a nephrotic syndrome and so on. As you see across the board, a variable proportion of patients with atypical HUS have anti-factor H autoantibodies. And that's an important cause that's kind of, been there almost about 20% if you look at the global data. In our country, for reasons that are not very clear, we seem to be picking up much more of anti-factor H autoantibodies. These have been proven by sending samples abroad, and now we have been running our HUS lab for almost close to 15 years. And almost about 55, almost half of all children would show anti-factor H autoantibodies. Almost 75% of children who present at the age of 5 to 15 years would have anti-factor H autoantibodies. And perhaps, this is occupying such a large chunk. We seem to detect a lower proportion of CFH, CD46, and other types. This is data on almost 150 patients in a prospective database. So it's not a small number of patients. So our proportion of yield in terms of factor H or MCP or others is lower compared to other parts of the world. Next slide, Aditya. Now, as physicians, as pediatric nephrologists, and also as genticists, one can make a guess as to the underlying etiology of HUS based on the age at onset, the proportion of kids having relapses, the likelihood of recurrence, and the variable post-transplant recurrence. As I said, that our commonest condition is anti-factor H autoantibodies that typically presents kids between 5 to 15 years. A proportion of them would have relapses, but the risk of post-transplant recurrence is low compared to, say, factor H or factor I disease, where the risk of recurrence is much higher. CD46 is unique, CD46 is a membrane-bound factor. It does not respond to plasma exchanges. Therefore, diagnosing this is important, that one should diagnose. Very high risk of relapses, close to 90%, 70 to 90%. But fortunately, a small proportion goes on to kidney failure. Factor C3 and factor B, fortunately, are less common, but they cause a really severe disease. And as is shown here, a very high proportion would end up with end-stage kidney failure, and there would be a high risk of recurrence. Now, with the availability of eculizumab, clearly these risks are going to be redefined. And we will talk about this later, but this is the pre-eculizumab era, where the risk of recurrence was clearly so high, given these conditions were there. Next slide, Dr. So, when you are faced with a child with HUS or thrombotic microangiopathy, now these were our guidelines published in 2019, and they have been reasonably endorsed by the ITNA, which is the International Pediatric Nephrology Association, as well as by KDIGO has its own algorithm, but broadly speaking, the flow is similar. So, Kamal, when you talked initially about what kind of a approach would one have, this is the approach which most clinicians would follow all over the world. So, when you get a patient who has got TMA, as defined by schistocytes, thrombocytopenia, acute kidney injury, the first thing is to exclude sepsis, because septicemia can produce exactly a similar picture. Septicemia, if a patient has, we could say that this is sepsis associated TMA, but this is not HUS. One would evaluate for malaria, dengue, leptospirosis, which can again have a similar picture. If it's an adult, and I'm sure there would be adult physicians in the group who are listening, if it's an adult, particularly if the platelet count is persistently below 30,000, one would have to confirm or exclude TTP, because the management there is totally different. Fortunately, in children, TTP would account for about 7% of all TMA, and it's much less, so it's not really a big deal for us. But this, and Aditi will discuss about the issues concerning TTP evaluation when she speaks next. So we would need to have assays in which you can diagnose TTP with confidently. If these two are excluded, then you are coming to HUS. Again, given that we don't see so much sugar toxin associated HUS, but it was an important cause before. So if you do have a history of dysentery, one would definitely think about sugar toxin, and Aditi will again talk about the diagnosis of these disorders. In the absence of dysentery, one is not sure. Now, because sugar toxin associated bacteria, particularly the E. coli, need not always cause dysentery. And about 20% of our patients who have got complement-mediated TMA may just have diarrhea. So we would advise, that if a patient has diarrhea, one should evaluate these patients for sugar toxin associated disease, because here again the management has to be is essentially conservative. You don't need to be aggressive with plasma exchanges and eculizumab and so on. So clearly, if you have diarrhea or dysentery, think about this. About 5 to 10% of all HUS in adults as well as in children is due to cobalamin C deficiency. Now, these assays are not so tough, measuring plasma homocysteine would be available in most good hospitals. But when a patient comes, at times it's tough to get their report immediately. And it's important to be able to pick up this diagnosis, because here the therapy is highly specific. You don't need to kind of give eculizumab or do plasma exchanges. You need to manage them in a different sort of manner. So we would recommend that patients, whenever you're evaluating these patients, please take samples for plasma homocysteine, simultaneously folic acid as well as B12, and keep those samples at -20. One may have to go back to these samples if you later don't find a cause. So we would kind of advise that keep these samples at -20 when you get a patient with HUS. Now you've got this big chunk of secondary HUS, more in adults than in children, but children also could also have this. The good thing about secondary HUS is that you're able to pick up based on the clinical features. So one need not do lots of very comprehensive evaluation to be able to say pick up lupus or APLA. These things are evident with simple investigations which are available: drug-induced cancer, following stem cell transplant, or following organ transplant, and so on. Malignant hypertension is a slightly dicey thing. I won't go into details here, but if you have questions, we'll answer. Pneumococcal HUS, we don't encounter too much in children in our country, but worldwide it would account for about 3 to 5%. So if you have a big pleural effusion or a subdural effusion, and you have pneumococci that are cultured, that would be a marker for HUS. There are some soft markers, the direct Coombs test being one. Usually the peanut agglutinin test that is specific for pneumococcal HUS is not usually available, chiefly because the condition is not that common. But please, pediatricians in this audience would need to keep this in mind. Now, having excluded these conditions that may also cause HUS, then you are left with atypical HUS, or what we now call complement-mediated HUS, wherein, and Dr. Aditi will be talking about this in more detail, one would be sending samples for C3, doing estimations for anti-factor H, which would account for almost 50% of all our children with HUS, much less in younger children, much less in adults. And we'll discuss about genetic screening, what to screen, how much to screen, and so on. So I'll stop here, Kamal, and maybe Aditi can take over, and unless there are questions at this point.
Sure, sir. Thank you so much. I think we'll probably request Dr. Sinha to do her talk and then take questions, because probably the questions are going to be covering both your topics. I'll just do a quick introduction for Dr. Sinha. Dr. Aditi Sinha is a distinguished pediatric nephrologist at AIIMS, New Delhi, with extensive expertise in managing complex kidney disorders in children. She's actively involved in clinical care, teaching, and research, with a strong focus on pediatric glomerular diseases and kidney transplantation. Dr. Sinha has significant experience dealing with pediatric atypical HUS as well. Dr. Sinha has also contributed significantly to national and international guidelines and has numerous peer-reviewed publications to her credit. She is widely recognized for her work in advancing pediatric nephrology and improving outcomes for children with kidney diseases in India. Over to you, Dr. Sinha. Thank you so much.
Thank you, Mr. Shah. I think that kind of extensive introduction not merited for me. I think what we have is our mentor is with us, and in fact, sir has. I'm just taking after him, including in this talk. These slides are very much his, and thank you, sir. So we'll just take this forward a bit. We will not have too many slides. I hope the slides are continuing to be visible. So, sir has already emphasized certain aspects of testing for specific forms of HUS, which are not categorized as atypical HUS. A couple of things that are important for pediatricians, pediatric trainees, and pediatric nephrology trainees to know is that testing for Shiga toxin is not simple. I mean, in the past, we've had a very challenging situation when we would have to, I mean, the guidelines would recommend that we are to document stool culture positivity for an organism that can produce the Shiga toxin, as well as demonstrate the toxin in an additional manner, be it by PCR for the Shiga toxin type 1 or type 2, or by demonstrating the antigen presence in the stools, because short of that, the diagnosis of STEC HUS is not confirmed. Fortunately, we do not see so much of STEC HUS, but culturing, unless you take stool samples in the acute phase of diarrhea, dysentery and diarrhea, the yield of culture might be low as well. And in patients who are not making stools immediately on arrival to the hospital, a rectal swab can also be taken. But more recently, we would be using the stool biofire assay for just rapidly culturing the stool and picking up the organism based on the DNA lengths, etc., that are present. They will be able to identify for us the STEC pathogen. And overall, the yield is low, and the context is important. So when you are testing in the presence of dysentery, probably you expect to see it, particularly in a child who's older than 6 months, presenting to us with dysentery and an HUS-like setting. In the presence of diarrhea, the yield would just alone without dysentery, the yield might be low. Likewise, testing for pneumococcal HUS, the recommendations are to demonstrate the organism, the Strep pneumoniae organism, which is difficult to culture, as you know, that requires certain culture criteria. So you have to culture it from blood or from the fluid that where the infection is. So maybe the CSF in a patient presenting with meningitis, or the pleural effusion, if you can tap it and you culture it and you demonstrate the organism, and also demonstrate through the peanut agglutination test the unmasking of the TF antigen. Now, the peanut agglutination test is really not accessible. So it's usually a setting of an invasive pneumococcal disease. A young child who has had an invasive pneumococcal disease is suspected of it, in which you would suspect this entity. But you would also want to ensure that what you are seeing in terms of microangiopathic hemolytic anemia, thrombocytopenia, and AKI is not just part and parcel of the disseminated intravascular coagulation. So, I mean, DIC itself is a cause of TMA, and all the DIC that occurs in an invasive pneumococcal disease will not get called as strep pneumonia HUS. Basically, when the infection is settled, the child is defervescent, and the hemolysis continues unabated, is when you suspect this entity. Cobalamin pathway defects and ADAMTS13 sir has already dwelled upon. There should be some precautions in collection of samples for these, because we don't suspect them right away. It is important to store samples, as EDTA plasma sample could be stored, separated, and stored at -20 to -70 degrees for a long time before you do the total homocysteine assessment on that. But this sample has to be taken before any form of plasma therapy. And the sample, I mean, you can't just store just the EDTA blood, but it has to be separated as plasma and stored. The second assay is even more difficult to access. I mean, cobalamin pathway is more of a thing that you don't think of right away when you encounter a patient with pediatric HUS. And very often, many labs would be doing total homocysteine, but you don't remember to take those samples. But you have to remember to keep these samples. Usually, it is a diagnosis that we come to afterwards very often, but it's important to do the diagnosis timely, because therapy is very, very specific. You would need to give intramuscular hydroxycobalamin, as well as betaine and folic acid in this set of patients, and they respond pretty well. For ADAMTS13, as was suggested, I mean, it is a diagnosis that you make more often in an adult patient presenting to you with TMA. The platelet counts would be quite low. AKI may not be that severe. There might be multisystem involvement. The expectation is to take samples, the citrated blood sample, and again separate the plasma and quickly process it, or you can store it at -20 to -70 degrees, as long as you've collected it in citrated vial and you have separated the plasma. So again, collection is very, very crucial here. And the method of assay is, the recommended method would be to look at the ADAMTS13 activity, and a FRET-based assay is required, and very few centers are doing it. So in the governmental setup, for example, only CMC Vellore was doing it till recently. Through some project funds, we have managed to establish it temporarily. But again, I mean, it's a very expensive affair, and to sustain it, one would require sustained funding. I hear that it has been done regularly at Gangaram, I suppose, but there are a few other private labs, but the charges being exorbitant, very often it's difficult for patients to afford these tests. Would there be any comments on this slide? Would you want to add on here something, Professor Baga?
Okay. I think please carry on here.
Yeah. The complement assays. Obviously, if you have a low complement C3 level, you would suspect strongly a diagnosis of atypical HUS complement dysregulation in this setting. But C3 may not be always low. Maybe in about 40 to 70, 50, 60% cases, you would have a low C3 in a patient with complement-mediated TMA, but not always. However, if the levels are very, very low, then one has a pointer towards certain problems such as a gain of function defect in the C3 gene, or even a CFB gene gain of function. These would tend to have lower C3 levels. Patients with anti-FH associated HUS would also have low C3, but the levels of C3 are modestly low. They are not extremely low. They are more in the range of 50 to 80 milligram per deciliter, more or less. If you have a very low C3, again, think of other conditions such as autoimmune entities such as lupus, wherein you would also have accompanying low values of C4. In a patient who's coming to us in a pediatric setting, in the age bracket of say 4 to 15 years old, our first possibility that we think of is anti-FH antibodies, that this disease must be mediated by antibodies to complement factor H. Herein, thanks to funding secured by Professor Banka and collaboration with French collaborators, Professor Dragan Dure, the assay for anti-FH was established at this center in 2010 and has been running at about 7 to 14 days frequency all year round, all these years, thanks to ongoing funding from project to project by support by the DBT, DST, ICMR. The assay that we run is a tedious process. It requires overnight incubation, and subsequently calibrators are run with each assay, positive controls from assay to assay, and it's an important exercise that requires calibration from time to time with close attention to the assay conditions. Now, this assay gives us the yield in about 55% to 57% of patients constantly that we sample as atypical HUS in pediatric age bracket. This has been consistent since 2010s to up till now, that the proportion who turn positive are about 55 to 57%. It's as narrow as that. And it's very important to emphasize the fact that there are many kits now that are available for doing anti-FH assay. In fact, these kits have been there in the market since 2010s. And in a methods microbiology paper in 2014, these kits were also tested against all other methods or different research labs performing anti-FH ELISAs, and a meeting to just kind of meeting and discussions around these assays and comparisons of testing methods had revealed that the method that is followed at this center, which takes after the Paris method, the French ELISA method, seems to be the most robust way to assay for anti-FH antibodies, providing good titer assessment in terms of the antibody levels, and would be the most appropriate assay to use. These kits that have been in the market, such as from the Vidya and from certain other companies, I'm forgetting their names, they do provide information in terms of positive and negative, but the utility of these kits in being able to provide the appropriate level of antibody is questionable, to say at best, because if you read the kits, they would be tested on very few samples, and even that paper had criticized that they have not been tested well enough. We understand that some labs in the country are also taking after other labs such as Newcastle Lab and other labs and have established their assays, but there have been from time to time discrepancies in the reports, and therefore one would suggest to continue with the method that we follow. Measuring levels by ELISA for factor H, factor I, factor B do not seem to be useful in different research labs they are performed, and most researchers in the domain would suggest that measuring these levels are not useful because they may or may not be low in a setting of atypical HUS, and low levels may not mean low activity as such. We had also established in 2014-15 a flow cytometry assay for measuring surface expression of CD46 on the surface of leukocytes. While it was useful to pick up homozygous deletions very appropriately where surface expression was not happening for CD46, it again may not give a proper, it may not have the best sensitivity for picking up missense variants, etc. Soluble MAC has been a marker of complement activation state. However, again, the sample collection process is a bit tedious. you have to freshly do the assay or a freshly collected sample and separated plasma. Otherwise, the level of SMAC would fall rapidly and would not be reliable. Again, this is only limited to research labs, and currently we are not using this. So I think I would just invite Professor Bagga for any comments that he has to have on the complement assays, and then.
So I would just say that apart from C3 and anti-factor H, doing levels of various complement factors is not really required. And most labs don't do it anymore. We did invest a lot of time trying to establish factor H, factor I. So I think after this, the next step is genetics. So
Yeah.
Aditi,
Yeah, I think we would like to take a pause here and so ask our colleagues what, because we have panelists with us, or do you think?
Yeah, unfortunately, I think the panelists, if they've joined as attendees, please let us know so that we can.
I mean, we have Dr. Neerja and Dr. Puri as well, right?
Yeah,
So,
yeah, Dr. Yes, of course.
Yeah.
Apart from them, if other panelists have joined as attendees, please ping us so that we can promote you to the panelists. In the meantime, invite Dr. Puri and Dr. Neerja to please add your comments and questions, if any.
So my questions to them would be that what tests would you advise, and in which patients with HUS?
Neerja, you'd like to comment?
Please. Hello.
Hi.
Hello, sir. Good afternoon, all. So I think we learn atypical HUS through you, sir, and the patients that you are sending to us. The major problem that we encounter with these patients, that when they get the reports, they have many different types of mutations and deletions which are not very much known to everybody, or even to the genetics fellow, that these are common deletion or we can disregard those. So the testing is as you said, that it is important to understand the genetics of atypical HUS because it has implications for the therapies. So I think we probably should be discussing about, once Dr. Aditi, you present, and I don't know whether we have some cases to present over here, because we keep getting those consultations through adult nephrologists, and for the pregnant ladies also, whether they should be carrying with the pregnancy or not. So these are the dilemmas which we are encountering in our practice, and have started seeing these atypical HUS patients and the genetics report. So otherwise we were not seeing such patients because they are typically going to pediatric nephrologist and you as a whole. So I think probably we should have more discussion if we have something related to genetics, and then we can have discuss more. Thank you.
I also agree with what Neerja saying. We've also seen these patients through referrals in the hospital, and whether looking at the panel of genes to see the variants, interpret them, whether they are pathogenic, likely pathogenic, or if the WOOS variant is it really a relevant variant? Based on what Dr. Aditi had previously mentioned, you have some genes which are functional as loss of functions, and there are a couple that are gain of function. So sometimes by the nature of the variant, we are able to make that out. And then the dilemma which I have till today is what relevance and how impactful, and is it really required to do MLPA for the rearrangements? So I think these are a couple of things that are very important to discuss, because there are a lot of opinions. I have read extensively because it's not crystal clear as how you have to really assess the rearrangements, which are fairly common. And I remember once writing an email to Dr. Smith, who also works a lot on atypical HUS, and he told me just disregard them. And so I think we'll be really happy to discuss it after the presentation, Dr.
Okay. So.
No, please carry on. Then I think it's okay. Yeah, just carry.
Okay, so I mean, like, in the interest of completing this topic, I mean, what we would recommend is performing a whole exome sequencing and an MLPA. I mean, if whole exome sequencing does not indicate relevant variants. But for our context of pediatric patients, our first step in the algorithm is to first look for anti-FH antibodies. And we do know that in patients with anti-FH antibodies, we do expect no additional variants of any importance in the whole exome sequencing. We do expect to see in 88 to 92% cases a homozygous deletion of the CFHR1 on MLPA screening. But given that it will be there, and otherwise in 9% of normal population also it is likely to be present, the homozygous deletion, we do not recommend testing by MLPA per se, or even whole exome sequencing in patients who have tested positive in high titers, in high levels of anti-factor H antibodies. Patients who do not have antibodies to complement factor H are the patients who we would subject to whole exome sequencing. In interest of time, we would do both tests together, whole exome sequencing and MLPA. And finding of a significant variant, as Sir has already mentioned, is likely in about maybe a total of maybe 15 to 25%. I don't think we have a higher yield than that in the current context. So the important thing is that not all HUS would be genetic, but complement activation, evidence of complement activation, either on assays or otherwise, would be present in the majority of these patients. And initiating therapy in a timely manner would be very, very important here. And while complement inhibitors are the current standard of care for all patients of atypical HUS worldwide, given its the lack of access to complement blockade in this country, especially until last year, plasma exchanges have been the standard of care, and this is what was advocated in our 2019 guidelines also, which were consensus guidelines for management of atypical HUS in settings such as ours, where complement blockade was not accessible. Plasma exchanges are essential because they bring in fresh plasma, remove the old plasma, which might have aberrant complement factors, and are replaced by fresh plasma containing active normal complement factors, and or remove any autoantibodies that are causing the disease. Now, plasma exchanges have to be started within 24 hours of diagnosis of atypical HUS. You require to do double volume exchanges on a daily frequency using either membrane-based or flow centrifugation-based technique of plasma exchanges. You exchange the plasma daily until you achieve hemat remission. Hematological remission is usually attained within 5 to 7 days with plasma exchanges. And when we say hematological remission, we mean that platelet counts have climbed up to above 1 lakh consistently, and the schistocytes are stably low, and LDH has come down to say around the upper limit of normal, that is about 450 units per liter. And the concerns, however, there with plasma exchanges. Plasma exchanges is obviously an invasive process. It requires a line to be placed. Most patients with atypical HUS are sick enough to require line placement anyways for reasons of need for hemodialysis. So when they are doing hemodialysis in our units, we would do plasma exchanges also alongside there. There are obviously concerns with a vascular access placement. There could be injury with the vascular access placement. There could be infection. There could be thrombosis. These are real risks, and large data sets would describe them as important problems in young children. The younger the child, the more the risk of these complications. Fortunately, in anti-FH associated disease, which is older children, we tend to encounter these complications less often, and in them, anyways, line placement is essential. Plasma can be associated with allergies, as you are well aware, and obviously repeated plasma exchanges would expose you to sensitization. After having achieved hematological remission, we tend to make the procedure on alternate days, given 1.5 times or 1 volume exchanges, and then taper it off. Previously, we used to do about 16 to 18 exchanges. Now we have come to use an abbreviated protocol of about 10 to 12 exchanges in our patients with anti-FH associated HUS. However, in patients with genetic forms of HUS, the length of plasma therapy is not determined, and it is very well established now, especially with data from the complement blockade era, that plasma exchanges compared to complement blockade offer a suboptimal kind of care. There is a higher risk of kidney failure, particularly in genetic forms of atypical HUS, with plasma exchanges than eculizumab. There is a very high risk of relapsing illness in complement-mediated HUS with plasma exchanges than with eculizumab. In the private sector, cost of plasma exchange is also a problem because it costs almost, it's very variable costing, but cost of plasma exchange is often as much as a vial of eculizumab. One thing that is important to emphasize is that eculizumab has come in since 2008 or 9 in the guidelines internationally. And there's enough data now from registries and from large cohorts from various countries to indicate that complement blockade has changed the way this disease outcomes are there. the disease outcomes have improved so much that in small countries in Europe, it has been shown that deaths and kidney failure due to atypical HUS has gone away because of the use of complement blockers. So in the West, a patient who walks in with atypical HUS would receive the first dose of eculizumab within 24 hours of the diagnosis, and subsequently continue on eculizumab till the results of genetic testing are available. So genetic testing is not required for initiation of therapy by all sorts of guidelines across the world, including the Kidney Disease Improving Global Outcomes, International Pediatric Nephrology Association, and also now the Indian Society of Pediatric Nephrology guidelines that are being worked out. So what we are looking at after starting therapy is hematological remission as our first parameter. Kidney recovery may take time, it may take longer. Particularly when you're using eculizumab, you do not use complement C3 as a marker, but when using plasma exchanges, you could see improvement in complement C3. Importantly, it doesn't seem to require lifelong therapy anymore. The complement blockade when previous guidelines, and we'll come to that in a bit. In anti-FH associated HUS, fortunately, in our country, it being the more common cause, we have found good benefit using plasma exchanges and immunosuppression. This is registry-wide data from the country in a database established at this center for patients across the country. And over 130 odd patients were collected in this early publication 2013, in which we demonstrated that inducing hematological remission and getting off dialysis was made easy with use of early initiation of plasma exchanges and oral prednisolone, followed by IV cyclophosphamide, 5 pulses, and then maintained therapy with tapering doses of oral prednisolone and additional use of MMF. We subsequently have tapered the plasma exchange protocol from 18 exchanges to 10 to 12 exchanges, and we are beginning to look at more abbreviated schedules for maintenance immunosuppression with MMF in this group of patients. But this protocol seems to work. In fact, we have some data now to suggest that plasma exchanges induce hematological remission more rapidly in patients with anti-FH associated HUS than does therapy with eculizumab or other complement blockers, based on just looking at case reports across the world and database data from our center. However, this disease is a severe disease, and we need more data on kidney failure outcomes, etc., particularly in context of the two therapies, and head-to-head examinations are required. Relapses are common in this disease, and therefore maintenance immunosuppression seems appropriate. However, the length of this immunosuppression is being kind of determined. Another approach would be in the West that you don't test for anti-FH antibodies at all, and you directly send for genetics while initiating therapy with eculizumab, and you may or may not add on immunosuppression once you get the result of anti-FH antibodies. This approach has been seen in some small centers, small cohorts in different centers in the world. And people who use this approach obviously favor this approach. But as I said, maybe there is a slight advantage to plasma exchanges and anti-FH antibodies in inducing hemat remission. Of course, I mean, this needs to be established better. We have in last year at the beginning of when eculizumab was beginning to come to this country, when licensing was happening, when AstraZeneca made it available, around that time we published this guidance for use of eculizumab in atypical HUS, in which we have specified various indications. Mind you, I mean, obviously, as I said, for the diagnosis of atypical HUS, we follow our algorithm. We do not await any genetic testing, and then the therapy has to begin either with plasma exchanges or eculizumab. So for a patient with atypical HUS, either of these therapies would be essential. Where you consider that a genetic disease is more likely, such as a very young child, a relapsing illness, a patient with a family history, wherein you definitely prefer eculizumab to plasma exchanges, given the fact that it is likely to be a genetic disease, and plasma exchanges would have to be stopped after a while anyway. So eculizumab is the preferred therapy for patients with atypical HUS, particularly young children, and in those in which a family history of HUS is already known. Plasma exchanges, we tend to prefer for cost reasons and feasibility reasons in patients with anti-FH associated HUS, but in refractory cases, therein also eculizumab would have a place. Now, the dosage, adverse effects monitoring, this guidance is provided in this guideline document, which was published in the Indian Journal of Nephrology, and interested residents and trainees could have a look at this. It is very useful to provide therapy to patients. One must remember that there are certain forms of atypical HUS which will not be complement mediated but are inherited defects and will not be amenable to therapy with eculizumab. And while these are very, very rare, one has to be aware that these are described in recent papers, such as from the UK group in 2023, which described a variety of neurological entities which were associated with atypical HUS and could also have refractoriness to eculizumab. Likewise, there are other variants which are also associated with other kidney diseases that are described on this slide. We also know about, obviously, the cobalamin pathway defects that will not respond to complement blockade, as also a certain variant in DGKE, homozygous disease caused by homozygous variants in DGKE, which present in infancy usually with nephrotic range proteinuria and the triad of HUS is met. Therein, complement blockade would not be useful. In secondary forms of TMA, eculizumab has been tried from time to time, and there is controversial data in this regard for various forms of TMA, whether or not complement blockade is useful. Chiefly, the data that seems to support some evidence being present is for patients with hematopoietic stem cell transplant developing post-transplant HUS. Therein, there is some data to suggest that complement activation is present, and therefore therapy using complement blockers might be useful. There is limited data on other things such as refractory lupus, drug-induced TMA, other infections, etc. Certain infections such as influenza, very anecdotal reports. I mean, one must remember that patients with STEC HUS are unlikely to respond to complement blockers. However, there were early anecdotal reports in which complement activation was demonstrated, particularly during the European small kind of epidemic, wherein the sicker patients were given complement blockers, and it was shown that it may or may not have benefit in patients with cardiac dysfunction or neurological disease. When this was prospectively examined in two large studies, the AccuSTEC trial, and I mean, there were two trials that examined it, and did not show supportive evidence for use in STEC HUS. So I'll probably just take you through this fact that, I mean, thankfully, with complement blockers, originally the data suggested that, I mean, the guidelines recommended that therapy should be continued lifelong in patients who have genetic variants. But it seems increasingly possible to discontinue therapy after a few months of therapy in majority of patients with pathogenic or likely pathogenic variants in important genes regulating the complement pathways. But at least 6 months of remission must be documented. In the variants of uncertain significance, people have tried to take off eculizumab even earlier and managed to maintain remission. Definitely, when you don't have a significant variant, or if you have variants in genes that do not respond to blockers, or you have a patient with anti-FH antibodies, we probably would take off therapy earlier. But at least 3 months of therapy and steady remission would be warranted in these cases as well. I think we would also know that patients with complement-mediated defects tend to recur after transplantation, particularly so with likely pathogenic variants in the key regulators like CFH, CFB, C3. And therein the risk of recurrence is very high, and two approaches have been tried. Either you start peri-transplant before transplant and carry on through the transplant period onto post-transplant period for a variable length of time, or you have a very close monitoring approach and you do rescue therapy with eculizumab as soon as recurrence happens. Both methods have their advantages and disadvantages. In the more high-risk situations, one would probably prefer a prophylactic therapy approach rather than a rescue approach. So I'll stop here, sir. And sorry if I took too long.
No, not at all. Thank you so much, Dr. Sinha, for that very insightful talk. I'll open it up now for questions. Dr. Ratna, I think you have your hand raised. Over to you, ma'am.
Yeah, thank you for excellent talks. Thank you so much, Aditi. So we understand that if the anti-FH antibody is present, we don't need to do genetic testing, but we do know that normally there should be a homozygous deletion in the hybrid genes if we do an MLPA. Is there a correlation, because you found 50% antibody positive in India compared to the rest of the world? And supposing for somebody the antibody testing is not available, say in other parts of the country, is it appropriate to do the MLPA and, just take it on from there because the managements are different in a symptomatic patient?
I think I'll ask Professor Baka to take that question and answer it.
So clearly, the proportion of patients who have the polymorphism in India is similar to the data worldwide. It's not as if, there is much more polymorphism, CFHR1-3 polymorphism in the deletion in India compared to the rest of the world. The figures are almost like 10 to 15%. There are some reports from Africa wherein they've reported polymorphisms to the tune of 20%, but then there is no HUS data from there. But that's immaterial. So coming back to your point, that do we need genetics in an anti-factor H? We would currently feel that it's not required, because you would get the polymorphism, the CFHR1 deletion, and in almost 90%, and it has no implication. Your other comment, that suppose one does not have access to anti-factor H autoantibody, can and has HUS, and if he has a polymorphism, can we assume that he has anti-factor H? I have no answer really. Aditi, do you want to answer this? That HUS, but we would still suggest that doing anti-factor H, because doing an anti-factor H assay, Dr. Puri, also once you do an assay, you also need to then follow up these patients for at least for at least a couple of years. Looking at their titers, looking at their course. So just relying on MLPA will not be a good idea, even if in a setting of HUS. And theoretically, you may still get 10% HUS without
deletion.
Yeah, deletion on its own. So I don't think one could replace anti-factor H assay with MLPA. Coming back to your previous point, Ratna, I think about 2 to 3% of all HUS where we don't find a cause do have hybrid genes. And this is underreported. So clearly, if the genetics is negative,
whole exome is negative, then
the whole exome is negative, and the anti-factor H assays are negative. One should carefully look at the MLPA data. You can't diagnose hybrid genes based on MLPA alone. You will have to probably do more careful genetics, including Sanger sequencing and so on. But at AIMS, I think currently there are a couple of patients. Aditi, how many do you have, wherein you've got a hybrid gene causing familial HUS with multiple deaths in the family? Aditi.
Yeah. So, hybrid genes, the conventional CFHR1-3 deletion or heterozygous deletions are not meaningful, but hybrid genes are important, wherein you have a small part of the CFH going away and it coming up in the CFHR4 or CFHR1, etc. location as a duplication somewhere. We have also been told by our French colleagues that a pattern of MLPA in which you have a CFHR one homozygous deletion flanked by two heterozygous areas could also be a pattern that suggests to you a hybrid gene. They will have to sequence that area carefully to figure out whether there's a hybrid there or not. We have a family, for example, who had twins. One twin succumbed. The other twin came to us with HUS. We started eculizumab, maintained her. Given that 2 labs in genetics on whole exome and MLP reported nothing major except some heterozygous deletions, as I said, we took off the therapy and then the girl relapsed. We had to reinstitute therapy, and she's currently on eculizumab, God knows for how long. And we need to sort out this hybrid gene business with her, because we were told by the French lab in that context that this does look like a setting wherein maybe we are missing with our probes, available probes, a part where CFH is really knocked out and there's a hybrid gene. So it's chiefly a last part of the CFH, because of the meiotic recombination events homology there, that these hybrid genes might happen, and CFH, a small part, is missing.
And there's a very high chance of recurrence.
Yeah.
And in fact, it's very well said, that all the complement genes show variable penetrance. You could be carrying a factor H heterozygous variant for life, and then suddenly at 50 years you get the HUS. The same is true for CFI, even more true for CFI. But for the hybrid genes, for factor B and for C3, these are highly penetrant genes. So the disease does manifest early enough. Otherwise, it could be variably penetrant. Aditi, there are a couple of questions,
Yes, sir. So one of the panelists has asked whether one must do genetics for considering transplantation. Should we? So on the Q&A, we had this question that whether in a transplantation context, genetics is necessary or not. So how do you advise that? Should the recipient undergo testing if the history was like of HUS?
We would obviously do a evaluation, and one would also screen the parents for the same gene. Suppose you do get a variant, and even if the mother or the father who's donating is carrying the same gene, one would not accept that as a donor. Nirja, what do you think?
Yes, sir. We would, with all this genetics, I think it is better to avoid that person as a donor. And in any case, for any of such transplants which are happening for other conditions, liver transplant, etc., HSCT, we avoid donor to be a carrier, or because,
Exactly.
and
Yeah,
more so because of the variable expression and the incomplete penetrance. So it's
absolutely.
generally better to avoid.
Yeah.
Yes.
Thank you. Thanks. Aditi,
I
second
think,
question.
Yeah.
sir, an important message to give, because this is something which is not uncommon, is there is no need to do MLPA in a asymptomatic donor.
100%. Yes.
I think
And
that's important because there is a lot of anxiety with that.
yeah, people should understand, that when you are transplanting, say 100 diabetics, 10 of those diabetics would have a CFHR1 deletion. You don't
Homozygous deletion.
the 10% of the donors, you don't reject those donors. You still accept kidneys. So when you do the same for diabetes, so clearly one should not be doing a MLPA to reject donors in cases of HUS as well. In fact, we have had children, Ratna, who had
Anti-FH disease and transplanted.
consanguineous families having a CFHR1 deletion. The parent was a donor. He also had the CFHR1 deletion. He still gave the kidney, and as far as I know, the kidneys are
He's
still
fine.
working. The kidneys are still going, and the dad is also okay. So having a homozygous CFHR1 deletion is not a concern for HUS.
For recipient as well as donor.
For recipient as well as donor. Yeah. So I think it also answers this one question.
Yes, so there are two questions about heterozygous variant. So if we are not concerned around homozygous, we are also not concerned around a heterozygous variant. So here it is, we get patients considering transplant donors, AHUS in a patient showing heterozygous variant in the concerned gene, which is a common polymorphism, mother donor also harboring this variant. So there's no concern.
Yeah. Agar CFHR1-3 is there, Professor Sankar, and if it's a CFHR1 heterozygous, I would not worry at all. I would not. One would just go ahead.
Yeah.
And the similar question by Dr. Agarwal.
Yeah.
In a case with HUS.
Yeah. In a case with HUS with homozygous or heterozygous deletion CFHR1-3, would you consider testing potential donor for these deletion? If yes, would you reject donor on the basis of presence of deletion? So no, we would not worry around the CFHR1-3 deletion in the recipient, nor would we test the potential donor for the same.
Please do remember that these are polymorphisms, and Nirja and Ratna would agree, that polymorphisms really means that it's there in a very large proportion of the population. So if there are 100 people listening to this meeting, 10 of us are carrying the CFHR1-3 deletion, or at least the CFHR1 deletion. So it's a very widespread
polymorphism.
Polymorphism.
Can I ask one question before we close, Aditi? You had talked about a value. If the anti-FH antibody is high, we don't go to exo, to find the gene variant. So do we have a cutoff?
Yeah. So, ma'am, based on testing in normal healthy volunteers and 5 standard deviations above that, our lab had established an value of 150 arbitrary units per ml as the cutoff for normal threshold. However, patients with anti-FH HUS would typically present to us with titers exceeding 1,000, usually exceeding 2,000 arbitrary units per ml at presentation or at relapse. If you have an ambiguous zone such as a 150 to 500 units value, therein I would worry that this is not because of anti-FH antibodies. I mean, the disease seems tough to explain. So you have raised your hand. Yeah.
First, Kamal.
I had a question, sir. If you want to add something to the current question, maybe you should go first, sir.
Yeah, so Ratna, while the Indian society has taken this stand, there is some degree of controversy with the IPNA on this. The IPNA guidelines do say that do evaluation. So do a genetic evaluation in all patients with anti-factor H autoantibodies. I kind of tried to reason with them, but they did not listen. So while we do take the stand, the listeners should be aware that it's not totally cast in stone. So suppose particularly if a patient is going in for a transplant, perhaps you may still want to do genetics.
Yeah. So, sir, the patients of anti-FH-HUS in whom we do testing would be the ones who have either low, modest titers of antibodies at presentation. We could also do in cases where they have a relapse and they don't have an associated increase in antibodies as we expect, or if they are going up for transplantation. If there is any chance of them being familial, which has never been the case, that would also be a context, sir.
Okay.
Oh, thanks so much. Thank you.
Can I ask one question? For at times the genetics is not available as you said, and then on what basis if you want to apply for rare disease policy, and then for
Something,
how should we be stratifying those, given
yeah.
that it is essential to have that genetics before proceeding
Yeah.
for the therapy? That is one question. Second is, you have modifiers for many such conditions. So how do you deal with the modifiers? Because we are doing exome sequencing, and there are chances that you get some of the variant in the modifier genes as well, which is implicated in atypical HUS. So what is your take on that?
I'll go first and then I'll request sir to add on to it. First thing is that in the atypical HUS, once you define someone as having atypical HUS, therapy has to be started immediately. So, I mean, ideally speaking, we should have a system in which the rare disease program also has an acute kind of a system in which when you decide that this patient has atypical HUS, at that time, you give a provisional kind of an approval for initiating therapy. We don't need your approval, but we need the funds basically. So we start the therapy with eculizumab, and we start therapy and the continuation of that therapy beyond the results of genetic testing will then again, after the results of genetic testing come in, then the rare disease committee has to review the application to understand whether to continue the therapy or not to continue the therapy. Ideally speaking, in an ideal world, that should be the way that we start therapy no matter what. This is atypical HUS. And if there's no genetic variant, then you can decide to stop therapy at 3 months of diagnosis of atypical HUS. If it is a rare genetic variant which is likely pathogenic, in that case, you continue therapy for at least 6 to 9 months before you try to give that a break and monitor closely. If the child relapses, you restart therapy and then you continue forever. So,
Nirja. So I'll just try to kind of just rephrase what Aditi and exactly saying the same thing. So HUS is a medical emergency. So therapy has to begin immediately. And I keep on telling, colleagues all over the country that it's like an antibiotic. And if you delay, you may have kidney loss or you may have a patient loss. So therapy has to begin right away, preferably within 72 hours to prevent kidney failure. Now, that's one. Also remember that with whatever tools we have, 30% of atypical HUS or complement-mediated HUS, we will not find a cause. Even worldwide data says that 30% HUS, you don't have a cause. That's the second point. Third point, 2 years ago, there was a large amount of data from the Newcastle registry. They looked at their data on almost 30 years before and after eculizumab. And they looked at, genetics gene-matched outcomes. And what they found was interesting, that if you have a pathogenic or a likely pathogenic variant in a complement gene, and if the likelihood of recurrence after you stop therapy was 1 in 10 per patient year, 1 in 10 patient years. So 1 in 10 patient years, you would have a recurrence. But if you have got, and the same is true for a VUS. So even if you've got a VUS, now I must say that in HUS, VUS is not to be ignored, and we have learned this the hard way. And even the Kavanagh's paper said that LP, P, and VUS, the risk of recurrence is almost similar, almost 1 in 10 patient years. But if you've got no variant, and that's what you're saying, Nirja, the risk of recurrence is very, very low. And that's why the current guidelines are now shifting to just treat for 3 months, get the patient out of the acute crisis, and then you can stop. And the risk of recurrence is almost similar to the general population. So I would say that HUS, when we send genetics, if we get a pathogenic or a likely pathogenic or a VUS, we will have to be more careful. But if you don't find a variant, I think one can stop therapy in 3 months' time. Now, whether it comes in the ambit of rare disease or not, it doesn't matter. But I was at this last national rare disease meeting, जो कहाँ पे हुआ? I'm forgetting where it was held more recently. a number of units in the country are not using a genetic diagnosis for HUS to define this as an indication for rare disease therapy. So genetics is no longer a necessity to be able to apply for rare disease for HUS. And I know that in a number of centers in southern part of in South India, clearly there was a, in fact, it's going to be a policy soon. I don't know when. Maybe you would be more aware about it, Nirja and Ratna, than I would be. But then I also understand the implications of a rare patient getting the drug versus buying on his own and so on. I'm not going into that. So this is where we stand.
Modifiers, do you have anything to say? We don't know of any precise modifiers, do we? But we would just want to emphasize variants.
The modifiers are there. Nirja, you are right. People have shown that people who have one variant, if you've got one variant versus having two variants, say in CD46, as well as in CFI, there's a much higher risk of getting HUS. In addition, there are some risk haplotypes. Interestingly, when we looked at about 100 patients, we did not find any risk haplotypes in the Indian population, I must say. And there are two risk haplotypes, one in CD46, I think the other is in MCP. Sorry, in factor H.
CFH and MCP. So.
CFH and MCP. If you have got these risk haplotypes, the risk is higher. But then we did not pick up, I'm sure they must be there.
I had a question, sir. I think the National Program for Rare Diseases, the Atypical HUS India Foundation is coming across a few patients from various areas of the country where, the applications are being delayed, and I suspect that the decision is not being taken because of the want of a genetic test, and so is there something that can be done to, AIMS is a COE. Now, there are other COEs in the country that are probably not aware of the genetic test not being required for initial approval of the disease, right? Like rescue vials initially, immediately, like you said, within 72 hours.
As of now, there is no such policy in place where genetics is not required. To correct you.
But we are going to...
But we are informally. That is what we are trying to...
Actually, whatever discussion has happened recently, not recently, some months ago, that genetic testing is required, is essential for starting the therapy. And sir, उसमें ये भी बोला कि VUS को हमें disregard करना पड़ेगा because not for atypical HUS, sir, as such, because many people are getting many conditions. People apply for several conditions like immunodeficiency.
I agree. Yeah.
So if we open this VUS, then there will be a lot of issues, and
I agree.
So that is why the exception for HUS, it is not written anywhere that for HUS it is going to be an exception that genetic testing is not required, and VUS we can ignore, or we should not be taking.
Suppose we take it one step at a time. Yeah.
So wo abhi next CTCRD meeting, I think maybe you can make a case that this is required and this is essential.
Genetic testing is required. There's no question about genetic testing not being required. It's required, but a positive genetic report is not required to initiate therapy. Imagine it's your own child who gets HUS and whose report is negative. What do? You say, "मैं therapy नहीं दूँगा." So so look at the other side of it,
Yes, sir.
So it's
this is for getting funding through rare disease policy only.
I know. I know.
So within that only. So that's what. Yeah. So within that only. I mean, one thing is the message to the clinicians is that we have to start therapy. Regardless, I mean, genetics will come later. But the message to the rare disease committee, what we want to make is a couple of submissions in this regard that we have been saying just now, that consider having a framework in which a deserving family in the absence of genetics, like the case that we narrated in a success story recently that you might hear, for example, you don't have the genetic diagnosis, but you know that this is a familial picture, this is a patient who needs therapy. Such therapies should be accessible at the discretion of the COE faculty. There should be some discretionary power in your hand. Secondly,
and Aditi, can we stop therapy in 3 months in those patients?
So, I mean, if you don't find anything, only then, no? Otherwise, how will you?
But ये बोलना कि genetics नहीं करो is not a right message also, Genetics is obviously essential.
Yeah.
In India, we have to do genetics, but the report should not dictate the
Yes, sir.
initiation of
Choice or
Yes, sir. Fully
indication.
agree, sir. But the submissions that Aditi is trying to make, these will require permissions from CTCRD and
I
the
know.
discretion. We do not have any
Let's
discretionary
take it
power.
there. Just that we take it there. Give us a window to take it there. Yeah.
Yes. So you can give us some evidence, and जो भी चाहिए, we will call you in that meeting जब भी होगा. I don't know whether it will be reconstituted or what. So, yeah. If you can provide it through email, then I can forward it to the central committee, Aditi. Okay.
Sure, I'll discuss with sir about this. Definitely.
I think we'll have one last question, which is there in the chat box.
There are
Kamal, you had to ask a question, no?
I asked my question.
You've asked.
Yeah,
Okay.
there are a couple of questions in the Q&A.
Okay,
as well,
there
if you can
is.
quickly,
In case with hybrid genes, what is the prevalence of anti-factor H antibodies, sir? If the hybrid gene is present without antibodies, what is the significance? I think we answered this.
In case of hybrid gene, what is prevalence? Normally, anti-factor H autoantibodies will be there in association with the CFHR1-3, chiefly one deletion. Hybrid disease
is a different
thing.
Hybrid is different.
Hybrid का मतलब ये है कि ना, it's not a deletion, but there is a recombination, and that's causing trouble, So that's a different disease. Fortunately, Dr. Kanan, it's a rare condition, I would imagine that hybrid would happen 1 in 100 cases. So overall, it's not a very important thing. Professor Shankar asks, for COE, the procurement is based on the confirmed diagnosis. The medicine is not available, and Nirja is the best person to answer him.
Yeah, we just
I
discussed on
think
this.
that's what we want to put up, that it should be available.
Put up like this, that some provision should be there. It's not yet there, obviously.
It's not only for atypical HUS, Shankar. It is also for many metabolic conditions where treatment is not available and we need it. So this provision is not there as of now. So
I think step by step. We are in an era where provisions are being provided. It is beyond what we ever dreamt. And I think the next step would be the emergency. So we have to appreciate what's happened, but we have to go a step up in the ladder to make it available for emergency. And I think, Dr. Bagasa, just one thing for all our colleagues there. I think there is this little confusion between the hybrid and the deletion. The deletion is a simple event. It's not disease related. The hybrid are the gene conversion events because of recombination, which is significant, but not common. And that is associated with disease. I hope I've put it across correctly.
Almost invariably, they would involve part of CFH. Whereas the other events that you're talking about would not alter that.
CFH.
There are a couple of more questions on the Q&A if we could just quickly take, and then we can wind up.
So one question is, can AHUS present as malignant hypertension, TMA? Do we need to consider genetics in them? So
nobody knows. Ishan, it's a tough question, People have shown that malignant hypertension, TMA, could be a manifestation of atypical HUS. And there have been, some reports that if the malignant hypertension is not controlled well using standard antihypertensives, one could consider eculizumab. But these are mainly case reports, I would imagine not even case series. So I don't have the real answer, but if you looked at the slide that Aditi showed on secondary TMA, she did show, that people have considered using eculizumab for malignant hypertension. Weber asks, what's the management approach for a female patient with complement-mediated AHUS during a first pregnancy who now wishes to pursue a second pregnancy? Who had complement-mediated HUS? So I assume
this is a real case. So we discussed this case also.
Yeah. So I assume that a complement-mediated cause was found in the first pregnancy. So a genetic defect was found. Who now wishes to pursue second pregnancy? I also imagine that perhaps the outcome may not have been very good in the first pregnancy in terms of the fetal outcome. But even if whatever the outcome was, but I don't know the answer right away, and maybe one needs to discuss this patient in some more depth. But I would imagine that a patient who wishes to pursue a second pregnancy, we do know that pregnancy per se is a risk factor for the precipitating HUS, atypical HUS, and she would well be a candidate for eculizumab use during pregnancy if required, if she does get a HUS. Aditi, do you have to add anything? Maybe I'm not answered.
No, so that's right. I mean, basically, pregnancy as well as any other kind of stress event could be any other surgery, any other stress could also be an event that triggers TMA in someone who is genetically predisposed. A second hit could be any of these circumstances. We should have eculizumab available for rescuing if that's the case. That is the thing. I mean,
And
the
this
case,
yeah.
that we discussed with you and with Dr. Nirja was a patient with a CFB variant in which the first pregnancy was ended with a TMA and the fetus did not live, and she got off dialysis afterwards, but now she wanted to go for the pregnancy. And she has a CFB variant of uncertain significance. And we felt that the location of the variant was such that it was introduced to a hotspot and there's a fair chance of recurrence. But that fair chance of recurrence is there for her lifetime anyway, not just around pregnancy. That should also be remembered. So,
please keep that in mind, because if she is carrying a complement variant that is significant, then she has a risk of HUS anyway, and so they would, in the current state, they would need to have access to the medication and a good physician, obviously, who can manage their care.
And so was eculizumab given to this lady?
No.
It was because of the cost.
This was the history that they came with.
Okay.
Dr. Nirja and sir, both we discussed this about 2-3 weeks back, this family. Yeah.
So I just wanted to understand that in the first pregnancy, because she stopped dialysis, she should have been given eculizumab if available. That would is the idea.
Yeah.
Okay.
So she had a termination of pregnancy for whatever reason, I'm not sure, and the term IUD or whatever, and then she had afterwards dialysis requirement, which is unlike what you would expect with eclampsia, and she did not have anything to suggest sepsis, puerperal sepsis, etc. And therefore, we felt that this was a TMA indeed. There was a kidney biopsy performed which showed TMA, and with conservative management, she could get managed. She continues to have some proteinuria and maybe some hypertension. So she has chronic kidney disease, but it's in a stable situation and it's a young person.
Thanks. Thank you. I think there's one last question by Nirja. What is the role of screening first-degree relatives if you find a pathogenic variant in the CFI gene?
Stress causing.
The Pandora's box.
Yeah.
पता है Nirja, CFI थोड़ी सी गड़बड़ सी जीन है.
CFI CFH मान लीजिए, इसको CFH मान लीजिए. CFI is a controversial.
CFH is probably a milder. But अगर CFH माने और अगर किसी को HUS हो गया और अगर किसी को obviously heterozygous variant होगा, so the family may want to know, but it's something that you may know, and Nirja, even the parents may be carrying and they're doing well. So perhaps one would just.
I mean, counseling is all about giving them their choices, isn't it? And that's what you probably do, Dr. Nirja.
What do you say, Nirja?
Sir, I'm not sure. ये मैंने नहीं पूछा है वैसे क्वेश्चन.
अच्छा.
आपके नाम क्या है?
आपके नाम क्या है? आपने किसी फेलो को दिया होगा ना?
मैंने तो ग्रुप पर डाला था वो.
आपके फेलोस पूछ रहे हैं.
I have a thought here that if you do test and supposing they do have a problem later, at least one knows the direct path rather than going crazy at that time and working things out. But of course, it's not an easy thing. It's like knowing a BRCA variant. You may never manifest.
We have a family like that who has C3 variant, which is with a low C3 state. The kid presented at less than 1 year old. She was on dialysis for a while and then got off, and she has had a relapse afterwards. She has been on eculizumab for a year and then got off. She didn't have a relapse. Her sibling and dad were tested. They had low C3s, so they got tested by Sanger, and they have low C3 but never have manifested disease. And they have the variant. They have low C3, which means the gain of function amplification is going on happening, but they are well. Touch wood till now. But if they have the disease, they would have this benefit of knowledge, as you're saying.
Absolutely. Yeah.
It's a concept of counseling.
I'll request Dr. Puri to now closing remarks, and then we can wind up, I guess.
So, thank you so much. And I think on behalf of the Society for Indian Academy of Medical Genetics, along with the Atypical HUS India Foundation, very, very thankful and obliged to Dr. Bagasa and Dr. Aditi Sinha for the great input. It's a complex topic, and I realize the more you discuss it, it's only then that the cobwebs to some extent clear out. And I really thank all our participants as well as for the interaction that's come across through this webinar. So thank you so much, Mr. Kamal Shah, for putting this together.
Thank you.
Great.
Thank you.
Thank you.
On behalf of Sir and I, we would like to thank you for involving us and engaging us with the geneticists. This was very much required. And thank you for allowing us to be here with you. Thank you.
Thank you.
Thank you so much.
Bye-bye.
Thank you. Thank you, Dr. Nircha.
Thank you. Bye-bye.